Welcome this afternoon to our webinar on intervention tools to expand your practice, getting to know RehaCom and Cogmed. I'm Dr. Anne-Marie Kimbell. I have with me Dr. Peter Entwistle. We both work for Pearson Clinical Assessments, and we're happy to have you with us today for our webinar. Before we begin, I'd like to go over a few housekeeping items. This webinar is presented in broadcast audio, so please turn up your computer speakers to hear the audio. There are no dial-in options. If you do have any connectivity or audio issues, please click on the question mark at the top right-hand side of your screen for assistance. Please type any questions that you have into the chat box, and we will answer questions live, time permitting. If we don't get to your questions during this live time, you will need to submit your question using the link at the end of the webinar to submit your question so that we may respond. The webinar handout is under the chat box. Click on Event Resources, and you're able then to download the file. The only way to get a certificate of attendance for this webinar will be to fill out the survey at the end of the webinar, and then you will receive an email from do-not-reply@webcast.com with a link to your certificate. Okay, so we will get started. Today, we want to introduce you to two products that are used in cognitive interventions and rehab and training, and we'll tell you about Cogmed and RehaCom and explain how they're used to help patients who are engaging in general cognitive rehabilitation or cognitive training of working memory and attention. Before treatment interventions can ever begin, a careful assessment is necessary. This is often a combination of assessment procedures that are undertaken. One is involving standardized assessment tools, which tell us how a client compares to others of the same age or diagnosis and helps us to determine cognitive strengths and weaknesses. And then also other types of assessments involving functional and behavioral measures are undertaken, and these help us to look at how the patient and family possibly are coping, which problem areas may be the focus or the areas of focus for the patient and family, what compensatory strategies may have already been tried, what learning strategies may be helpful, etc. These look kind of at the practical problems that the patient may be having. But once this type of assessment has been completed and there is an understanding of the individual situation and the problems, the treatment goals and treatment plan may then be formulated, where a range of interventions may be carried out by various professionals. As I mentioned, the interventions are what the patient does or are done for or to the patient in order to help the patient complete their objectives or goals. So relevant to our discussion today, goals may be aimed at rehabilitation of cognitive impairment or general improvement of cognitive processes, such as improving working memory, for example. So cognitive rehabilitation can be considered a therapy program to help cognitively impaired individuals restore normal functioning or to compensate for cognitive deficits. And these, of course, may be skills that may have been lost or altered due to brain damage resulting from disease or injury. So cognitive rehab is also considered to be the use of a set of interventions which aim to restore or compensate for cognitive deficits. It's a two-way interactive process whereby people with neurological impairments work with professional staff and families and community members, so their treatment team, right, to alleviate the impact of cognitive deficits. The purpose of these types of cognitive interventions would then be to support people living with disabilities resulting from brain insults in to help them achieve their optimal level of well-being or to reduce the impact of whatever their injury has caused in everyday life and to help them return to their own most appropriate environments. But because damage to the brain often affects cognitive, social, behavioral, and emotional functioning, all these domains are considered when assessing for the impacts of damage and when planning treatment goals and interventions. But cognitive rehab seeks to address the impact of the cognitive insult. And so the overarching goal of the therapies of rehab in general would be the functional rehab of people with cognitive impairment, and it includes a number of strategies and plans to meet these goals. But today, in today's webinar, we're really going to focus on cognitive interventions, which are generally thought of, again, as a collection of individual treatment strategies designed to improve problems with memory, attention, perception, learning, planning, and judgment. that are brought about by brain injury or neurological disorders or other illnesses. There are specific therapies designed for each of the cognitive functions. So we're going to spend most of the time today giving you information about two specific programs designed as cognitive intervention programs. During most of the 20th century, we really thought that brain structures were fixed, solidified, after a critical developmental period in early childhood. After that period in early childhood, if you experienced a brain trauma, it was really assumed that you just have to live with the resulting deficits, the resulting cognitive deficits. But in the last few decades, researchers have shown that the brain's physical structures and functional organization can and does change in adults. This concept is called neuroplasticity. It's the brain's ability to remold and rewire itself. Neuroplasticity is a response then to changes in behavior, environment, thinking, or emotions, and a key to this restructuring is repetition. So let's talk about ways in which cognitive functions are restored. One way is restitution. That's the reestablishing and strengthening of the damaged neural pathways. This is a healing process, and it applies in situations where neurons are damaged but not dead. So this could be, from something like short-term ischemia or pressure damage from a hemorrhagic stroke or from the stretching caused by TBI. So again, the neural pathways that are damaged but not dead, these can be reestablished and strengthened. And then another way is reorganization, and that is developing and strengthening new neural pathways. This is, of course, a neuroplastic process, and it may involve kind of a slight detour to go around a damaged area or a total reassignment of a cognitive function to a completely different area of the brain. And in reassignment, it often occurs that a function is reassigned to the contralateral side of the brain, so the same area on the opposite side from the damaged area. And then another way of recovering cognitive function is compensation, and that is the use of new strategies or external aids. And the most common of these are memory strategies or external memory aids like notes and day planners. In terms of practical therapy, though, there's not really that much difference between restitution and reorganization. Whether the old neural pathways are being repaired or new ones are being built, the results are the same. The neural pathway and the cognitive function are restored. The compensation, on the other hand, is used to deal with existing cognitive deficits without restoring neural function. But long-term use of internal strategies can induce reorganization in the areas being used as well. So what is the role of cognitive rehab in restoring cognitive function? Well, it can promote and accelerate restitution, it can promote and accelerate reorganization, and it can be used to teach and practice internal compensation strategies and teach and practice, of course, the use of external aids. So what does the research say? Is cognitive rehab evidence-based? Well, over the last 20 years, there's been a large body of evidence that has emerged supporting the use of cognitive rehab. And in 2011, the Cognitive Rehab Task Force of the American Congress of Rehab Medicine, reviewed 112 separate research studies. These studies comprised 370 interventions for stroke and TBI patients. Their conclusions were that there is substantial evidence to support interventions for attention, memory, social communication skills, and executive function, and visual spatial rehab, and so forth. And the paper also concludes that future research should move beyond the simple question of whether cognitive rehab is effective and examine the therapy factors and the patient characteristics that optimize the clinical outcomes of cognitive rehab. If you think about it, there's considerable heterogeneity among treatment methods that are reported in the literature, and it's difficult to compare interventions even when these are purported to represent the same type of treatment. But research does show that there's sufficient information to support evidence-based clinical protocols, so they should be used. In 2014, to update this study, the Cognitive Rehab Task Force of the American Congress of Rehab Medicine conducted a meta-analysis of a more recent 121 studies. So they systematically reviewed another 121 studies of cognitive rehab for people with TBI and stroke, and their overall analysis for this meta-analysis indicates that cognitive rehab is of significant benefit They made 29 recommendations for evidence-based practice of cognitive rehab. The evidence supports practice standards for attention deficits after TBI or stroke, visual scanning for neglect after right hemisphere stroke, compensatory strategies for mild memory deficits. Sorry, I should change the slide. Here are the practice standards. Also for language deficits after left hemisphere stroke, social communication deficits after TBI, metacognitive strategy training for deficits in executive functioning, and comprehensive holistic neuropsychological rehab to reduce cognitive and functional disability after TBI or stroke. And then these are the practice guidelines also. So all of those are available in those. There were 3 studies. There's a 2005, a 2011, and then a 2014 update that was published in 2019 that all look at the evidence for cognitive rehab. So now I want to talk about RehaCom. This is the first of the 2 programs we want to introduce you to today. RehaCom is a computerized cognitive therapy that was developed by scientists and clinicians and researchers in Germany more than 25 years ago. It's a pretty sophisticated system. It's been used and refined since the late 80s in German-speaking countries, and it's now used around the world. It's by far Europe's leading system for computer-aided cognitive rehab. But over the past 5 to 7 years, RehaCom has really established itself with therapists across the United States and has become an indispensable therapeutic approach. It provides clinicians deficit-specific, targeted, evidence-based, patient-centered treatment based on the science of neuroplasticity. And so it's for use with patients as young as age 8. Targeted cognitive rehab, as we talked about, is an essential tool in the rehab process. RehaCom addresses 4 core areas of training: attention, memory, executive function, and visual field. RehaCom has 9 optional screening modules that can be used prior to beginning therapy to suggest areas of impairment and highlight intact functions. The therapy plan is then created to meet the specific needs of the client, target specific goals with the client to ensure their best chance of success. There's 28 configurable computerized therapy training modules that continuously auto-adapt to the training level of the patient. And these therapy modules include therapy targeted to discrete cognitive functions, as well as specialized and more complex modules for treating several affected cognitive functions. So the training modules cover a really wide range or wide level, including low training levels for those with severe cognitive deficits. I'll say more about that in a bit. RehaCom really is a tool, an intervention toolbox to make both the therapy and the therapist more efficient and more effective. It streamlines, it facilitates, it kind of amplifies what the patient is, what the therapist or the clinician is able to do. It frees the clinician from some of the routine tasks and allows them to step back and see the therapy kind of in a different way. It allows them to coach the client and helps them to implement strategies that blend the best of approaches while at the same time tracking performance. It is an entire toolbox. All of these interventions can be individually tailored to the specific needs and levels of the patient. As you know, the effects of damage to the brain, no matter the cause, stroke, TBI, tumors, multiple sclerosis, or other clinical conditions that impact cognitive functioning, they really vary widely from person to person and can depend on many factors, including an individual's personality and the severity and the location of brain damage. You probably have heard a number of studies are currently looking at the various effects, the various cognitive effects of the virus COVID-19. And although we don't have definitive evidence of direct impact to specific domains, we're hearing anecdotally and in some early research studies internationally and nationally that there are some both short and long-term cognitive effects of this virus. But again, they vary depending on the patient, on the severity of the disease, et cetera. So there's many patient types who can benefit from a system like Cogmed. Like RehaCom and then Cogmed that you'll hear about in a little bit. As far as settings, RehaCom is used in hospitals and clinics, in long-term care, in private practice, and now can also be prescribed for at-home use. So looking at in clinic, RehaCom really does lend itself to many care delivery situations, and this is really important for cost effectiveness and convenience. The software can run on the clinician's computer in the clinic, or it can be implemented in an existing clinic network over local area network or wide area network for multiple station licenses. And in this case, the patient's database is stored on a central server. Many clients can train independently, although at the beginning and the end of the therapy sessions, the client and the clinician may meet to determine the therapy goal and to discuss the results. And then RehaCom lets the clients complete their cognitive therapy independently, which allows clinicians to work with several clients at the same time if they wish. And then as a therapist, it's also possible to use RehaCom as a telepractice solution. It is now available as a home-based option. And with this method of delivery, home-based therapy is prescribed to the patient by the clinician responsible for the patient's cognitive rehab, and the therapy prescription is assigned from the clinician's computer and then transferred over the internet to the patient's computer at home. And so the patient can then launch and complete their training using special patient-specific software loaded on their home computer. And completed training results are then downloaded by the clinician to their computer for monitoring and therapeutic evaluation. So there's a keyboard that's available for use with RehaCom. Every patient, even those with severe cognitive or motor deficits, can be treated with RehaCom, but for some patients, especially those with severe motor impairments, a conventional PC or laptop keyboard is sometimes inappropriate or hard to use as an input device for computer-based therapies. So there's a RehaCom panel, this keyboard, and that can help make the program accessible for a broader range of patients. And it has really large buttons for OK, up, down, left, right, plus, minus. The keyboard is symmetrical, so the same responses can be given from the right or the left. Each therapy module is optimized to be used with the RehaCom patient's keyboard or panel. It's really large, as you can see. I mean, you can kind of see that in this picture, that it's large. It's pretty robust. It has color-coded big buttons, and it's really easy to handle and understand. And I don't have a picture here, but there's also a chin or headrest that allows patients who need this to stay in a comfortable way in front of the monitor, in a comfortable position in front of the monitor. The chin rest is adjustable in height. It's made of durable materials, so it can be cleaned easily, and it can be clamped to a table with a screw clamp. The rehab of cognitive impairments requires continuous treatment over time, and the duration of a therapy session with RehaCom depends on the client's personal performance. According to clinical guidelines, the protocol for training may include several times a day for 10 to 15 minutes in the acute phase. In the following 6 to 8 weeks, therapy sessions of 30 to 45 minutes, about 3 to 5 times per week, may be prescribed, and then 3 to 5 times a week for about 3 to 5 months in the late phase of rehabilitation. And as you see, each module can be set to last from 5 minutes to 60 minutes. So there's really a wide range of availability. RehaCom can be used, as I mentioned earlier, through all stages of rehab, from severe to mild deficits. The easiest training levels can be used at the acute stage, and then it can become progressively more challenging as it auto-adapts to the user's ability. Moderate levels up to very challenging levels are appropriate in a post-acute phase in an in-clinic or outpatient or home-based setting. In each training module, the user is presented with tasks that will automatically adjust what the user sees and what they hear based on their actual real-time performance. And so this ensures that the user is always working at their optimal level of challenge in each task. And that really supports motivation. It lessens boredom and frustration. Each training module is extremely rich in the variety and depth of content. It also allows for continuous patient progress tracking. And then the reporting of performance, as you'll see a little later, I've got some screenshots that'll show you this. It's pretty detailed. It's highly detailed, and it documents each user's activity and trends. They're easy to see and easy to understand. The therapist then can fine-tune the performance of each training module if necessary after reviewing the results, and they can vary the degree. They can vary a number of different things, but including the degree to which the patient receives instruction. Most of the therapy modules automatically adapt the complexity of each task to the client's actual performance. The program provides the user with what's considered to be kind of a just right challenge. So again, the requirements are neither too high nor too low, which again keeps the user motivated and helps avoid frustration. The type of auto adaptation is also configurable. For example, the default might be to go to the next level after 90% correct, or maybe drop to a lower level if only 50% are correct. But the clinician is able to change those parameters as well. So the clinician can make the progression criteria more or less difficult if you were so inclined. The clinician can adjust the training parameters to meet the training needs of each patient. There's a number of different kinds of training parameters that can be adjusted. So using RehaCom's 9 built-in screening modules, they're optional, but they provide a rapid assessment of the client's deficits compared with a normative group that's matched by age and gender. And then the software will suggest which training procedures to use based on the screening results. Screening results don't really provide definitive comprehensive diagnosis. So cognitive screenings really shouldn't be used as a replacement for comprehensive neuropsychological testing. But it's common for clinicians to be uncertain as to whether or not a patient is demonstrating behaviors that might suggest cognitive impairment or not. And so it's important often to quickly assess which of these patients are actually demonstrating cognitive impairment that might be contributing to a functional problem. So screenings are commonly used for the early identification of individuals who may be at potential risk for a condition or disorder. They may indicate the need for further evaluation or intervention. And then, of course, they're used to monitor progression of symptoms or response to intervention. And as I mentioned, RehaCom has these 9 screenings. You can see them here. I'm sorry that I put that in white font. That makes that a little harder to read. All of these screening modules deliver normative data in order to compare the patient's results with the data of healthy persons of the same age and gender. And the screenings are going to indicate the deviation from the norm value. I have a slide that will show this as well in a bit. But each screening has its own specific minimum duration that corresponds to the respective test goal. And the screenings last between 4 to 15 minutes on average. They're supposed to assist the therapist to find the right therapy modules. So they will suggest the therapy modules. They can detect which cognitive deficit the patient may have and the degree of severity, and then recommend therapy modules most suitable for treating the client-specific cognitive deficits. So alertness, selective attention, divided attention, spatial number search, memory for words, working memory, logical reasoning, visual field, and visual scanning.
Anne-Marie?
Yes.
Could you take a question?
Sure.
One of our listeners is asking how long it takes to administer this screening for all modules.
So each screen would last from 5 to 15 minutes, and so that's really going to depend on the patient's performance. But if there are 9 of them, right, then that's going to take from anywhere from, say, 15 minutes to 2 hours and 15 minutes, roughly, really depending on the performance of the patient.
Thank you. And are you aware of any research involving patients with substance abuse?
I will have to look on the 2 websites that I'm going to show in just a little bit. I do believe there is some, but I'm going to have to look for specific answers to that, or I'll show you the websites to check out in just a little bit.
Thank you.
Thank you. So each module can be seen as kind of a separate large training program. They're pretty detailed, pretty complex. Each is equipped with a separate parameter menu, which allows you as the clinician to fine-tune the many parameters to enhance training for your patient if you want to. This menu that you see here, looking at divided attention too, it just shows some of the parameters that can be adapted depending on the goal of the therapy module. Often the kind and the speed of the automatic adaptation can be adjusted here too. And in most therapies, the therapist can also decide things like how the patient should operate the training. For example, if they're using the keyboard or a mouse or a touch screen. So you can adjust the auto-adaptive features. You see one called Level Up. That's the number of correct responses required before the patient advances to the next level. Level Down is the number of consecutive incorrect answers before the level is reduced. You can use the default values that are shown here, or they can be adjusted. Sometimes you do want to make the task more difficult while remaining at the same level of difficulty. So you're able to make those kinds of changes. And you can limit the solution time. Other adaptations are things like if the client has poor vision, you can enter that in the client's profile, and then the software will compensate by increasing the contrast on the screen. Some of the modules have a zoom feature where you can hover over an object and it's magnified. If you enter a hemianopnia, the computer will shift important information to the functional side. You can set a self-evaluation, and then the computer will ask the patient how they're feeling at the beginning of each session. There's just a large number of modifiable parameters available for each therapy session. Yet again, you can use the default settings and let those auto-adapt if you choose. So let's look at some of the training modules real quick. Approximately 80% of stroke and TBI patients suffer from attention deficits, and so RehaCom has 13 attention modules. This large number of modules is really necessary because attention deficits are most common after stroke and TBI, and they're mostly related to degenerative and other diseases as well. And as you know, a good working attention level is foundation for all continued cognitive therapy. And attention is also multidimensional cognitive function. And we know from decades of research that specific attention deficits require specific types of cognitive training. The training needs to follow kind of a hierarchical organization. So this attention training modules they include the 9 components of attention. So alertness and vigilance and sustained attention, processing speed, focused attention, selective attention, divided attention, alternating attention, visual spatial attention. The therapy modules fully reflect all of those dimensions, and it's important to provide repeated stimulation and activation of the foundational underlying attention dimensions, especially at first. And as soon as a patient has mastered a foundational underlying process at a basic level, then a therapy module at a higher level skill can be chosen to help them. So this is just an example of some of the training modules of what they might look like. So you can see that the alertness modules, alertness and reaction behavior, responsive and vigilance, are considered easy. And then there are some harder ones that are spatial attention, so spatial operations, 2D operations, and 3D spatial operations, and then some even harder divided attention modules, divided attention and divided attention 2. I'm going to show you an example of divided attention 2 in just a little bit. So up to 60% of stroke and TBI patients struggle from memory impairment or suffer from memory impairment. So there are 7 memory modules. Memory problems really lead to difficulties in everyday life, not just show up on cognitive tests. We store all kinds of information in our memory, and we remember things in different ways and for different lengths of time. Sometimes you'll see patients who have difficulty making new memories, but maybe they're very good about remembering things in the past. They may have difficulties with prospective memory, the ability to remember to carry out intended actions in the future, like remembering to take medication in the evening. Information encoding, storage, or retrieval can be impaired. So memory trainings with RehaCom reinforce learning strategies and help to establish compensation techniques. So the system offers the 7 modules, and some of them, there's verbal, figural, topological, physiognomic, and naming content. They're pretty close to everyday life. They're also rich in variety, and the complexity automatically adapts to the actual performance. So looking at some of these as an example, you see, sorry, again, those are hard to read. That's working memory in the top left. Below it is figural memory. The middle top is topographical memory. Below that is memory for words. Top right, physiognomic memory, and then verbal memory below that. Working memory is really critical and limiting factor for cognitive control and executive function. So the working memory module supports both the storage and the manipulation components of working memory, and it increasingly evolves selective attention and inhibitory processes at the same time. The functionality of working memory really provides a basis for many higher cognitive functions, such as things like problem solving and speech comprehension, arithmetic, intelligence achievements, etc. So again, this is just an example of some of the training modules for memory. And then looking at executive functioning, about 75% of stroke and TBI patients suffer from executive function limitations. There are 3 executive functioning modules. Many higher order complex thinking processes happen without us being aware of them. They're known as automatic processes. Together, many of these automatic processes are known as executive function. So executive functioning includes all those processes that allow us to organize and make decisions and solve problems. It involves the way we monitor what's going on around us, the way we adjust what we think and do in response to that. So therapists are provided with these 3 modules with close to everyday life templates in order to train and strengthen things like logical reasoning, to practice shopping. Let me move to that slide. To train on a complex vacation planning module. So the clinician can, or the patient, supported by the clinician, has to identify and then consider solution relevant information, develop precise approaches to the solution, plan and analyze the approach to the solution in parts, and then recognize mistakes and steps that aren't effective, correct errors, and develop alternative approaches to the solution. So there's a lot involved with the executive function training. You would expect them to be complex, and they are. The visual field training, there are 4 visual field therapy modules plus 1 module for visual motor skills. Up to 30% of stroke and TBI patients have visual field limitations. Visual impairment is a really common finding after stroke and can have negative implications on quality of life, on activities of daily living. If you think about, with the visual field loss, you're unable to see a section of your field of vision, usually because the vision areas of your brain have been damaged, and the eyes themselves may work normally, but the brain isn't processing the images from one area of vision. There's a substantial amount of evidence that patients can be supported to compensate and adapt to visual field loss following stroke, though, using a range of strategies and methods. And so RehaCom provides systematic adaptive exploration exercises, saccadic eye movement, searching missing numbers, identifying shapes, searching and counting objects, reestablishing assigned perceptual functions by intensive light stimuli. They're also very complex. So some of these are valuable for patients with visual spatial neglect as well. And this is another common attentional disorder resulting from unilateral hemisphere damage, again, most commonly from a stroke. Patients with neglect just don't pay any attention to the space on the opposite side to their injury. A lot of patients recover spontaneously, but about 40% of patients have symptoms that persist. And so visual scanning therapy is widely used in rehabilitating patients with this type of neglect. That mainly involves encouraging them to explore that neglected side of space, often with the help of visual cues. And so the trainings allow the therapist to implement visual exploration and visual scanning training with the patient. So RehaCom also provides you with a visual motor coordination training, and this works on the basis of a tracking task. The patient has to follow a given movement using a mouse. So through the training task, where motions always reoccur, the patient's encouraged to anticipate individual patterns of movement with that type. This is just a couple of the visual training examples, the saccadic training and restoration. This is an old chart, sorry. We don't currently have available the chart that lists all of the currently available 28 therapy modules, but I wanted you to see what this looks like just in terms of how it's structured. So you see the attention group on the top left, the subgroup of types of attention, and then there are corresponding therapy modules, and then you can see the corresponding types of patients for whom these therapies would be recommended. Similar for memory, you see memory as a group, and then the therapy modules recommended, etc. Have a quick video to play. Sherry, if you could start the video. Sherry, can you start the video?
The RehaCom module, Divided Attention 2, trains the division of attention between visual and auditive modalities. This ability enables us to consciously pay attention to two different aspects without neglecting one of them. Training with this module is indicated for patients with neurological diseases such as stroke, traumatic brain injury, brain tumour, mostly in the frontal lobe, morbus Parkinson's, and multiple sclerosis, as well as for patients with psychiatric, gerontopsychiatric, and other diseases such as depression, schizophrenia, addiction diseases, and attention impairments in child and adulthood. The divided attention is a complex attention function. A stable alertness function is a precondition for this training. Patients with severely impaired divided attention should start the therapy with the RehaCom module Divided Attention 1. Before starting the training module, it is possible to individualize the training parameters. Via the Therapist menu, one can adjust the level of difficulty, duration of the session, instructions, help, or stressors according to the patient's needs. It is possible to change these parameters at any time during the training. The task in this module is to drive the car a certain distance within a given time frame. Whilst doing so, the street, the environment, and the dashboard have to be observed in order to react to certain stimuli. The auditive and visual stimuli will often be presented at the same time and therefore need differentiated reactions. The training begins with a low number of different visual stimuli. With rising difficulty, the number and size of stimuli will increase. In higher levels, different auditive stimuli will be presented.
On the M5 to the west of Birmingham in both directions between Junction 3 at Halesowen and Junction 4 at Bromsgrove.
As difficulty increases, the duration and frequency of stimuli will become shorter and faster. For high-performance patients, an additional visual stimulus can be switched on in the form of a rear-view mirror. RehaCom works auto-adaptively. The difficulty level will rise or fall depending on the patient's performance. With each change in level, the user will receive additional feedback. At the end of a training session, RehaCom will create an evaluation graph. Training results will always be saved automatically. The patient will then continue from this stage when starting the next training session. Please find further information on our website.
All right. I should have pointed out ahead of time that that was filmed in the UK, so you probably clearly saw that the car was driving on what we would consider to be the wrong side of the road, but that really was not an error on the part of the patient. I am unmuted. Can you guys hear me? Can you not hear me?
I can hear you.
Okay, sorry. Was responding to a text. I just wanted to make sure. Okay, RehaCom saves all the therapy results, and so a new therapy session is able to start where the last one has been finished, and so it's possible to control a course of therapy and to adjust therapy targets and goals based on the individual progress. The clinician has the ability to look at all of the data at any point and then further develop therapy strategies and make adjustments if necessary. So the process, of course, as I mentioned, screening is a good place to start. Sometimes a patient will arrive ready for therapy with a comprehensive neuropsych test evaluation and won't need to have this type of screening, but screening or a full evaluation is where you will start identifying deficits and then you design the therapy regimen to fit the patient's needs. You want to challenge the patient without overdoing it. If it's too easy, there's no challenge, there's no improvement. If it's too difficult, it just becomes frustrating. You're really looking for that kind of sweet spot with the maximum training effect. Training is pretty flexible, as we mentioned, and it can be adapted. Screening results are displayed graphically along a bar chart. You can see that each of the gray bars begins at the same value on the right, that column marked 50, 0, 50. That's the norm value. So you see the T-score, Z-score, percentile rank there at the top. So that's the norm value. The 50-0-50 is that average performance for a group of healthy individuals. And then the bars extend toward the left, and their length shows the patient's deficiency below normal. So the green, yellow, and red indicate 1, 2, or 3 standard deviations below the norm. Each gray bar represents a different screening session. So you can see that this patient has undergone 2 different screenings, one on May 26th and one on June 16th. Screening results then are summarized to the left of the graph. If you look over to the left to the discussion section, the screening module and the test are shown along with the screening date and the summary of the results, and then the recommended therapy modules following this screening result are shown bold at the bottom of each of those sections. So again, after each training, you look over the results and if needed, adapt the training parameters before the patient proceeds with the training. This adaptation is really the key role of the therapist in computer-assisted cognitive rehab, and it requires constant monitoring. The most important adaptation can be that level of difficulty, which is shown in the therapist menu when you start the training. The therapist selects the level for the first session, and after that, the computer can adjust the level automatically, or the therapist can also adjust depending on results of the therapy. So this is just showing you that you can see the results kind of graphically here. Another kind of graph you can see for many modules. For this one, for example, you can see without a warning sound, with a warning sound, and others you can see performance across, for example, the 4 timed quadrants of the training, etc. A lot of different information available to the clinician to determine suitability and determine if adjustments need to be made. Looking at some of the research, 2 of the most encouraging and rigorous studies utilized RehaCom and demonstrated not only the effectiveness of RehaCom in treating memory and executive functioning and increased connectivity and cerebral function connectivity of the hippocampus with frontal and parietal cortical areas, improvements in attention and new learning, but also working memory training that resulted in significant improvements on working memory, word fluency, and prospective memory performance. So they showed both a direct benefit and a generalization of training effects. Current U.S. studies that are undertaken using RehaCom are one showing the efficacy or looking at the efficacy of RehaCom to improve prospective memory in individuals with TBI, and another using RehaCom in a multi-context approach for stroke patients in acute inpatient rehab. And here are the 2 links that I promised earlier, looking at 2 different places where you can go to look at some of the research that has been historical foundational research for RehaCom, and also where you can find ongoing research. And one more slide on RehaCom before I turn it over to Dr. Entwistle to talk about Cogmed. I just want to make sure that you're aware that we have a RehaCom Pilot going on. This is a 6-month pilot program available through the end of December 2020. So this is to help you support your clients. We want to provide this opportunity for you to join our free RehaCom Pilot program. You'll receive a complimentary single-station RehaCom license for 6 months for in-clinic use, as well as 100 internet therapy hours for use by patients at home. So this does have a time limit. You need to sign up by December 31st, 2020, and there's the link to sign up. You can find it on our RehaCom page as well. So I'm going to turn this over to Dr. Entwistle to talk about Cogmed.
Thank you very much, Anne-Marie. One of the questions that did come up is when you're doing the driving task, is it only on the left side of the road, which might be confusing for American drivers? And as you've seen in the answer, no. In the US, the version does accommodate for the right side of the road, as it would do in Germany. And know also that that divided attention task is for driving, so the person has to go faster or slower based upon the speed limit, and also to go slower if there's a speeding police car behind him. And in addition to that, they are supposed to regulate direction. So there's a lot of different aspects to that executive and working memory task, although we call it divided attention 2. Divided attention 1 also has a train. So now I'm going to talk a bit more about Cogmed. And you might say, well, what is that? And the answer is it's a working memory training program. It's evidence-based, and it is an intervention for individuals that may need help with their working memory. So who does it help? The simple answer is it can help children, adolescents, adults, even elderly patients. And it is designed to improve their attention by training their working memory. As you found with RehaCom, individuals train their working memory under the supervision of a coach, who could be a psychologist, a speech therapist, or a health educator. So, the first question you may have is, well, how long has this been around? Well, Dr. Torkel Klingberg, who is a professor at the Karolinska Institute in Stockholm, Sweden, created this in conjunction with some gaming professionals around 2001. It was brought over to the United States and acquired by Pearson around 2010, and that's when I got involved. So I've been involved with the Cogmed program in the US and Canada, for that matter, for about the last decade. And Dr. Klingberg is an eminent researcher and professor at the Karolinska facility. And if you have any interest in learning more about him, that's how you can read up on the research he's been conducting and other aspects of the program. So it's been around for some time. And your question might be, well, what is working memory then? And I like to think of it this way, as a temporary storage and manipulation system. As Anne-Marie was describing, you need working memory for a wide variety of cognitive tasks, such as, are you able to problem solve and calculate whilst holding something in mind? So you need to keep information in mind for a short period. You can't just hold it there and do nothing with it. You need to actively process what's in that information. And then we need to update. You need to delegate what's more important. As Klingberg says, what am I putting a spotlight on? What am I focusing on? And as Anne-Marie reminded us, it's also important to block out extraneous, distracting information that might take us off task. It allows us to say, okay, I don't need to focus on that right now. What's more important is this part, and to keep us updated and focused on what really matters. And I remember one time saying to a young man in a car, you need to keep your eye on the road, otherwise you're going to have a problem, because you need to focus on the road ahead and not on perhaps what conversation or music is going on or what friends may be saying on the cell phone. So when you think about working memory, the next thing to consider is, how does it fit in with these other cognitive tasks? And the simple point is, it does play a role in conjunction with these other cognitive areas. So it allows us to inhibit impulses. It allows us to prioritize, sequence, and organize what we need to do, perhaps over a time period. Let's say, for example, you need to have a homework assignment done by a certain date. Can you break down the tasks you need to be able to accomplish it in that time frame? It does lead to academic success, but what's also clear is that if you have dyslexia or if you have dyscalculia or some other kind of a disorder, you may still need to have a task that remediates those primary areas. Working memory can be enhancing, but it's not going to substitute or replace for other interventions you may require. So who can benefit? And the simple answer is a wide number of individuals. Can normal children benefit? Yes. What about college age or adults? Yes. And in fact, I can give you a number of experiences where normal individuals that would like to enhance their working memory have benefited from this. Now, what about other individuals? Well, initially, Dr. Klingberg was thinking that this would be appropriate for children that have an attention deficit disorder, because what he's found with a large group of them is that they seem to fall further and further behind. And so Elena Westerberg did a research study where she showed in a cohort, a cross-sectional cohort, that individuals with an attention deficit may have a much lower amount of working memory, which prevents them from achieving optimally in school. Now, in addition to that, it may be important to enhance the functioning of individuals that have sustained a brain injury, or as Anne-Marie said, perhaps they have working memory problems because of stroke or perhaps a degenerative disorder. So it is essentially a program that can help individuals focus And what you will find is that as demands increase and individuals may experience what Klingberg refers to as information overload, you really need to be able to enhance your working memory to compensate. One of his books was called The Overstimulated Brain. So one of the things to be aware of is that we do need to have research that supports the use of this program, and we want to make sure that people are aware of what the program can do. Now, since its earlier, let's say, a presentation in the States, people have said, well, is it like a game? Is it like some other commercially available game that individuals can go to? And the simple answer is, what distinguishes it from the others is that there is scientific evidence to support its use. Many of these are randomized placebo-controlled studies, and I'll refer to that in a second. But further than that, it is the training method that requires the use of somebody to oversee and support and encourage task persistence. When it's difficult for the children doing the task, can they be encouraged to pursue it and persist so that the task doesn't become too overwhelming for them? And by taking the Cogmed program, can we actually demonstrate that they've experienced change and that results in sustainable change as well? So these are some of the ways in which it differs from a game. As my younger son said when he was first doing it, it's not like a game because it's not inherently rewarding. It is more like work, and it is something that is a challenge to do. So when we said that there's been a great deal of research, we find that something like 8 out of 10 individuals that complete the program do show measurable results. What does that mean? Well, clearly it's not going to work for everybody. And sometimes individuals have said to me, who does it not work for? And one group that appeared to have difficulty with that were individuals that had photosensitive epilepsy. I think that's not going to be the case anymore, and certainly it has been used with patients that have epilepsy, but just know that there were 1 or 2 tasks that might have triggered an adverse reaction in them. What I would point out is you do need to have individuals that are willing to work at it, and they should be motivated. And so one group of individuals that were looked at were those that decided, if I work hard at a task and I don't achieve anything, then that's because I wasn't going to accomplish anything anyway. In contrast to a group that believed, if I work hard at it, I should be able to accomplish a great deal. And so some of those individual motivators are important to look at when you identify individuals that may have a working memory deficit. How is it different from some other, let's say, working memory programs out there? There's a significant number of research studies. We say here it's about 120. This will give you an idea. This is a slide I inserted because I think it's important for you to recognize there's a great deal of research on adults. There's a lot of research on children and adolescents. There's research with typical adults, and we've been looking at their brain functioning. That's why it's in red. We've also seen it being used with individuals that have stroke or brain injury. And some of those individuals were close to a geriatric range. In addition, it's been used with success with individuals that have had hearing problems, or perhaps they have intellectual problems, in some cases, pediatric cancer. And in other cases, what we're finding is there's a substantial amount of research on children with an attention deficit. So just to be clear, I described some of that research in an article I wrote for the Journal of Applied Clinical Neuropsychology called Reviewing the Reviews. And some of that information has also been described in the claims and evidence document that you can find at the Cogmed site. So the old Cogmed program looked like this. And so it was game-like and fun, but as you can see, it's somewhat dated. And now what's happened is the Cogmed program has gone back to Klingberg and gone back to Scandinavia, where it has been updated. And so we now have a new version. There's a complete redesign, a reimagining A lot of the same platform will be easily recognized by people who've had experience with the older program, and licenses, username, passwords are all going to transfer over to that new platform, and this is going to occur with effect from tomorrow. So this is a web-based app. It's more modern, it's more simplified, it's streamlined. And what you can see is, to some extent, training is going to be more intuitive than it was previously. There is a reward-based incentive system. You'll see that it's going to be appearing more game-like for individuals that need that. There is a comprehensive coaching center available. And lastly, there's a provider global map where individuals can then advertise themselves as providing this program to different parts of the world. So there is a variable protocol which could be employed, and individuals could do either the standard or the light version. And we have found in data with older patients that actually a light version still results in some positive findings. You can also either do the regular design or the creative design, which enables the individuals to play more of a game and engage in building tasks afterwards. So one of the things to be aware of is that there are different periods of time for training, different frequencies, and also some other features that make it different. So it is quite different from the earlier version. It's been modernized and updated. We have that reward system where a person can now start to build the world as a result of having completed certain parts of the program. And in addition to that, as a coach, you will still have access to the data about how your clients are doing. You'll be able to monitor their progress, and you'll be able to see if they are performing the program with fidelity, and you'll be able to keep track of each one of them. So here's that global map. And as you can see, we're starting to fill it up with individuals in the states that are offering this service to clients. And just be aware that the older program is one that's still going to be supported through December of this year. But with the flash technology going away, we hope that everybody will now embrace that new program and turn to the new program to see how it may be more effective for them. One question that some of you are going to have is, well, we've listened to RehaCom, we've listened to Cogmed. What's the difference between the two? And the simple point I want to draw your attention to is that there are more modules in RehaCom measuring such things as memory, executive functioning, and visual field and neglect. And those are not part of Cogmed. Cogmed primarily focuses on working memory and attention. So if an individual is presenting with a TBI or stroke and they have other problems, just anticipate that there is more being offered by the RehaCom program. Although 80% of individuals may present with an attention problem, that's not all it is. And one of the things I'm acutely aware of is that if you screen for a visual deficit because the person has a hemianopsia and perhaps they need saccadic training to be able to identify gaps in their visual field, that's something that the RehaCom program can offer. It's not part of Cogmed. Secondly, there are two levels now of prescribed activities. You can have a variable protocol, but what you'll find instead is that the clinician who is employing this program with clients in the States, if it's a RehaCom program, can configure the way they want the program. So how long should the exposure be? Do they need directions or not? Is there a time limit? All of those things can be changed. And as I like to describe it, it's a little bit like having a Mercedes with all the bells and whistles. It gives you the opportunity to be able to adjust the parameters for your clients based upon what you think they need or how they've been able to manage. One of the things I have found with the RehaCom is that OTs and SLPs and physical therapists and even speech and language and reading folks will sometimes say, I just let the computer determine that. That's optimal. They can do that. But I often find psychologists, in particular neuropsychologists, like to see how is this patient going to do if they're not constantly reminded about the directions? How are they going to do if we speed up the instructions or if we leave those out completely? So sometimes the psychologists who are part of the team will want to adjust those parameters as Anne-Marie was describing, and you can do that. Is there any evidence that it works? And the simple answer is there's in excess of 100 studies now on RehaCom, and the last I heard, Torkel Klingberg was saying that there's closer to 150, so that 120 plus research study is probably one of the most up-to-date figures. So there's a great deal of research. And what does it say? That 80% of users observe increases in their working memory performance, and in many cases it lasts in excess of 6 months. For RehaCom, we're accumulating more and more research studies, but it should be understood, based upon what Anne-Marie was saying earlier, is that even if somebody has a diagnosis of, let's say, multiple sclerosis or even schizophrenia or attention deficit, that each individual with that diagnosis may differ from other patients that have that same problem. Now, we do know in research that's being conducted on traumatic brain injury or CVA, ADHD and MS, they can be of real benefit. But early on, the clinical neuropsychologist I was speaking to in Germany was saying, our goal is not to say, does it work for the average patient, or even to say that it works for the majority of rehab patients. Rather, what we can do instead is say, we can configure the program to the needs of the individual patient and provide that to them using the algorithm that's built into the program to adjust. And as the patient gets better and they can last longer and perform better, some of those tasks can actually be done over a longer period of time. And as part of a total rehab program. There's a great deal more to learn. And at this point, I'm going to see, Anne-Marie, do you have any questions that you'd like to ask?
Sorry, couldn't unmute. I do have a couple of questions. And I'm sorry, the first one that I'm going to ask you came in several slides back when you were talking about the research. And
yep.
So you said the phrase "with success," and the questioner is asking if that means that it is generalizable.
The first thing I want to point out is individuals that have done the Cogmed program and they have accomplished approximately 25 sessions over a 5-week period of time, because that was the traditional model, will show improvements in their working memory. And we have data to show that the working memory for auditory and also visual spatial working memory is enhanced. Now, if you said, well, does it show up as improved reading or improved decoding or improved calculation? The simple answer is this is not a reading program. If children have a sight word disorder, they will still have that. They may benefit from working memory training so that they can take advantage of special ed. I've also found that if you can enhance a person's working memory, they may find it much easier to do calculations. But one of the things we found with the Wechsler scales is that if you give the WIS to a child with a math disability, you may find that they have problems with fluid reasoning. They may have trouble with visual spatial processing, with actual processing speed itself. And so there are multiple components beyond working memory that may need to be addressed in order for those students to do well. So what we like to say is there are those far transfer activities such as enhanced reading or math that may benefit, particularly over time. One study that was done by Joni Holmes said math skills were enhanced 6 months later. It's as though having working memory programs enhanced the ability of children to take advantage of instruction that was being offered. On the other hand, if you're using immediate math skills as a measure of working memory, you may not see a benefit. So my simple point is working memory is going to enhance the ability of children that have an attention or a working memory deficit. And we can say that a significant number of these research studies have evidence of changes in brain functioning, and even different parts of the brain structures have been enhanced by the training. And it's really interesting to look at those. But if you said, well, how's that demonstrated? It might be found on a diffusion tensor imaging study. It might be found on a functional MRI. It may be found on some other tool that has been embraced by researchers looking at a person's neurophysiology. But just know there's quite a lot of data that actually indicates that there are changes in the way in which a brain functions. And I've described some of that in one or two of the textbook chapters that we've written, and I can give you references to those if you're interested. Was there another question, Anne-Marie?
There is one, thank you. The other one I'm going to give a quick answer to too, and then let you answer about Cogmed, and that is, are there training profiles that allow clinicians to familiarize with the program? I think it was probably about Cogmed, but just in case, I want to say that there's not specific training profiles for RehaCom, but because of the way the program is structured, you're able to create a sample client and run through whatever you want to. So you absolutely are able to familiarize with the program before using it for RehaCom. Peter,
and one of the things I would say is if you screen the patient, you can see what is it they need to do. And if you find the lower scores on that screening, that's perhaps where you want to start. So you may need to start with a simple attention task and make sure that the patient gets the therapy module for that simple attention before trying to take on other tasks that may involve executive functioning or memory. As you can also see that there are a wide variety of memory tasks included, as Anne-Marie was describing, and one of them even can be configured for the patient, so that, let's say a person has a deficit in recognizing faces, particularly of significant carers. It would be something that can be personalized for that individual patient need. Now, to come back to Cogmed, you can try it out. You can actually try out the Cogmed program and see whether you like it and how it works. And we're going to give you the link so that you can see that without having to do too much of a trial yourself. You can explore the different versions. It's going to be available in a number of different languages. And this is a brand new program that's been updated and made available to the state. So this is going to be pretty new and unfamiliar to a lot of clinicians in the US. But just know, yes, this is something you can try. Anne-Marie, I have you on mute.
Sorry, thank you. We just have one other question, and that is, will we offer training next year at APA? And the answer to that is, who knows what next year is going to hold. We could potentially be at APA. We'd be happy to be at APA. That we will just have to wait and see. That is all of our questions. I really appreciate. Somebody is asking about the cost for RehaCom and Cogmed. I've put both links back up at that closing slide. It's on the inside of your handout, so please be happy to visit both websites, and you can get the information about the cost for RehaCom and Cogmed there. Thank you all very much for attending. Yes, Peter.
Just one last question. I did have a client who was a neuropsychologist in the Boston area ask me, is this available for patients to do at home now? And the simple answer is yes, they can do it at home now. We've made that available to you. So when you think about, is this something I can offer? As we point out, this is another tool that you can now incorporate into your tool bag as something that can be done in the comfort and quiet of a family's home. Thank you.
Thank you. And thank you all very much for giving us your time and attention this afternoon. We're going to go ahead and close out. Thank you.